And welcome, everyone. I am glad that you guys are here for the second live stream here on the Medic Materials YouTube channel. We are going to be talking all about pacemakers today, and then, of course, we'll do a Q&A afterwards. Probably going to take, I don't know, like, I would say 40 minutes to talk about pacemakers. It's a little longer than the first stream that we had going. Let's see, you guys, I'm already talking to you guys on the chat, so thank you guys for joining. You guys can see that there. Let's see, let me bring it up here. Yeah, I'm glad, Blaine, that you're here. I appreciate it. I hope you watched the last one. I know that my mouth was kind of off sync. I tried to fix that tonight. It's literally what I've been trying to do for the last hour. I think I might have figured it out. But you know, this technology thing is just really difficult for me. So, yeah, I hope that the recording was good information for you. We're gonna, one of the coolest things, like Blaine, I know you listen to the podcast. I don't know if, anyone else sitting in the chat listens to the podcast or not, but by now we're all aware that I have a pacemaker, and, oh, cool. Awesome. I'm glad that it wasn't bad on your end, Blaine. But yeah, no, like I'm fairly aware, like I would hope that everyone is fairly aware that I have a pacemaker by now. It is not a large secret. 2 years ago I got it, and it's one of those things that it kind of just opened up my eyes to how little we know about cardiac pacemakers. And because I was always the one that, I'm sure we all did it too. Oh yeah, we go on a call, and next thing you know, oh hey, yeah, you got a pacemaker, cool. And the only thing we ever asked about it was, well, when does it go off? Does it go off like only when you need it, or does it go off like all the time? And that was literally it. And then I got it, and I was like, I learned all the intricacies of it, and these things are like high-powered thinking computers, and it was kind of bonkers how much I didn't know about it. And it made me put together a CME based off of pacemakers, and ultimately what I did was I just condensed that CME to what we're going to be talking about tonight, focusing really on the structures of a pacemaker, the different types of pacemakers, and then types of assessments that we can do, in the field that help us along to get more information, and possibly some stuff that you guys have never heard about that might, also help us figure out maybe if they had a syncopal episode, or maybe why they had a syncopal episode, or maybe a fall, or something to that nature. So let me pull this up here. All right, so like I said, Pacemaker Masterclass. Hopefully you guys can see my little dot there in case I need to, highlight anything. The Boston Scientific is near and dear to my heart, because that is the kind of pacemaker that I have. And ultimately, like I said, what do we always ask? We always ask the fact of, how often do you use it? And, does it go off some of the time, or does it go off all of the time? And, we're really doing a disservice to ourselves and our patient not knowing, all there is to know about pacemakers, because it realistically just makes us absolutely clueless. And hopefully after tonight, you guys are like, hey, I know a lot more about pacemakers. Literally, what is today? Wednesday. So Sunday this past week, I actually gave this exact CME, just the longer version, to the state conference here in New York. And it went over swimmingly. Like, people, it was a room, probably like 40 people with some Zoom people. I don't know how many was on Zoom, but, say there was 60 people listening, that's 60 more people that could go out to the field and be like, hey, I'm not clueless anymore. So here's some really cool things that I found about the history of electrocardiology, as well as pacemakers. So the first defibrillation occurred in 1775. I'm not even going to say these people's names because I'm going to butcher them. But this guy, Nikolaev, was a Danish physicist. So 1775, that is during the American Revolution that the first defibrillation actually happened, right? So this French guy in 1872 resuscitated a child by attaching one electrode to a leg while rhythmically tapping the myocardium or the heart muscle with another electrode. So here you are having your first resuscitation attempt, right, using electricity. This next physiologist, Augustus Waller, that's the only one that I usually get right, recorded the first human surface electrocardiogram in 1887. That is the first EKG. Okay. And then in 1892, 5 years later, they came out with A, B, C, and D, which then got turned to PQRST. So the waves on the actual EKG rhythm that we still use today, the P wave, the Q wave, the R wave, the S wave, the T wave, right? So then fast forward to 1949, and nine years later to 1958, you have multiple pacemaking devices coming to the market here in America and across the world. And just think, this is 1949, so computer took up the entire, freaking room, and all of the pacemakers did the same thing. They were literally built on carts, and these carts, were rolled around with the patient. Okay, so your first pacemaking devices were just after the Second World War. In 1958, the first pacemaker implantation was performed in Sweden. The system had been developed by a surgeon and a physician and was implanted on a 43-year-old engineer named Arne Larsson. It lasted 4 hours. Then they took that one out and they put a second one in, and that lasted 1 week. So thank God mine's lasted 2 years. I'm happy for that. So then fast forward a little bit more, right? And this Dr. William Chardak, who also partnered with an electrical engineer, are credited for the first long-term pacemaker in 1958. 2 years later, this long-term pacemaker gets implanted in a 77-year-old man with a complete heart block. They lived for an additional 24 months or 2 years after the insertion. So, and now you have, myself. I've lasted 2 years after my insertion, and people last, decades now with the new technology. And, there are rough estimates on what, how many patients there are worldwide with pacemakers. I've seen everything from about 500,000 all the way up to about 3 million. But the one number that I do see quite often is the 600,000 new yearly patients that get, a pacemaker. I was one of these new 600,000 2 years ago in 2020. So we got to remember that the heart is simply a fluid pump. It's designed to beat from birth till death to move fluid. That's all it does, right? It has electrical conductivity paths that actually create the squeeze, but literally all it's doing is pulling fluid in and pushing fluid out, okay? So when we understand that, now we can look at the electrical conduction pathways. So one of the things that if you guys want to participate in the questions that I asked, just toss them into the chat box. I will bring up my chat box here. So what is the natural pacemaker of the heart? Okay. When you're looking at the natural pacemaker of the heart, it's a nerve bundle. Okay. It's a bundle of nerves that come off of the vagus nerve. So the vagus nerve creates the electrical impulse that stimulates the SA node or the sinoatrial node, this bundle of nerves coming from the vagus nerve that sits right at the top portion of the right atrium, just at the superior vena cava, where the superior vena cava enters the right atrium. So we have this SA node, and it, sends an electrical impulse to say, okay, let's carry this impulse down through the down through the heart, every 60 to 100 times per minute. Okay. So now we think, okay, we have the SA node. Where is this electrical impulse going? You have the SA node, and then it's going to go down further into the AV node, down into the bundle of His, and then down into the Purkinje fibers. Let's see. Oh, look at that. This just in, message from Gerardo. Give me a few, and he might actually join us on the live stream just like last time. So that's pretty awesome. He might call in. So this is what your electrical pathways look like, right? So you have your SA node, your sinoatrial node. It beats intrinsically 60 to 100 times per minute if it's healthy. Then you have it come down through the atriums to the AV node, or the atrial ventricular node. Now, this AV node holds the electrical impulse for the splittest of seconds, and it holds it there to give the ability for blood to exit the atriums and fill the ventricles. If it didn't hold this impulse, it wouldn't have the time for the ventricles to fill, and our ejection fraction would go down. Okay, so once the AV node holds it, it goes to this bundle of His, and then the bundle of His goes down the left and right bundle branches to the Purkinje fibers, which go on the bottom of the ventricles. Okay, so if the SA node was to fail and not be able to give us the 60 to 100, the AV node in theory would take over. It beats a little slower, but it would take over, and it would be around 40 to 60 beats per minute. If that fails, then the Purkinje fibers are your third backup, or your second backup realistically, right? And they beat even slower, but they'll still give a beat of about 20 to 40 times per minute. So why do people get pacemakers? Well, I got mine because of symptomatic bradycardia, but there's other reasons as to why people might get them. They might have deadly arrhythmias like pulsed VTAC. They might have runs of VTAC that turn into ventricular fibrillation. They might have rapid AFib or AFlutter or SVT that now they have to be paced down from a high rhythm or a high rate down to a regular rate. Whereas mine, I have to be paced up to a normal rate. Heart blocks. If you have a 3rd degree heart block, there is no electrical, let's go back a slide. There's 2 slides. There's no electrical, impulses getting past the bundle of His because it's not getting down to the Purkinje fibers. So if you can't get electrical, impulses down to the Purkinje fibers, your ventricles aren't going to squeeze. So we put in a pacemaker to bypass these bundle branches and actually create that impulse from the bottom going upwards. And then heart failure, right? If someone has an MI and they have a weak and flabby ventricle system because of just happens to be where the MI happened, well, now we need to give it a little bit of help to actually formulate this impulse and squeeze. So everyone has a story. If you guys have listened to the podcast at all, then you may have heard the episode where I talk in incognito about my story. But here is my story. So I had to put it into perspective, starting at about 10, 12 years old, I started having these syncopal episodes where I would just, boom, pass out, hit the floor. And because I was a kid, they took me to the doctor because I had really good parents, and they would, the doctor would be like, oh, he must have just vasovagaled, or, oh, it must have been sugar, or, oh, it must have been, he was sick and overdid himself or whatever. And so I never really got checked out until I was a freshman in high school, and this was 2001. It actually, I had passed out a couple weeks before this in the yard, and my parents were like, yep, you're going to the doctor, and we're going to fight, and we're going to get you to a endocrinologist, a specialist. And I was like, all right, whatever. And they were like, you got to take a glucose tolerance test. So I was like, sure, whatever, who cares? Not even knowing what the heck it was. So on September 11th of 2001, I'm in the state capitol here in New York, and I'm getting a glucose tolerance test while I'm watching all of the befuddling happening on the news. And I go through, and they're like, yeah, he's fine. Cool. Fast forward, that was when I was 14. Now fast forward until I'm in my 30s. And I had a 8-year period in between then when I didn't have anything. And then I started having these syncopal episodes again. And next thing I know, when I'm 31-ish, my wife and I were at home. The kids were in bed. We were sitting watching, something on Disney Plus and having beverages. I go upstairs. I'm like, hey, I'm going to go pee. And next thing I know, I'm in the bathtub on my ass, unconscious, unresponsive to the world. My wife, being a flight nurse, comes upstairs, checks my pulse, and she's like, beat. Really long pause to the effect of she thought she would actually need to start CPR. And she's like, oh my God, calls 911 because she thinks I'm dead. I start arousing. She's like, oh my, now I hear her on the phone with the dispatcher. I'm like, what the hell's going on? Next thing I know, I nod out again. And she's like, talking to the dispatcher. By the time EMS got there, I'm up, I'm talking, I'm, downstairs. I'm like, I'm completely fine. Nothing ever happened. What do I do? Being a great paramedic patient, I RMA because that's what we do. So she's like, no, you're going to see your cardiologist. So I go and see the cardiologist with her, and they put in a loop monitor. Now that's just a little battery. It's about the size of a AAA battery, and it sits right on your heart, underneath the skin. And, it's literally just underneath the skin. You can feel it. It feels like a AAA battery underneath your skin. So I get that, and that all it does is watch your heart. It looks at rhythms, and it records at anything less than 20. So fast forward 14 months, and I'm sick, and this is like peak COVID now, and I got a fever. It wasn't COVID, but it was just I got a cold, and 3 o'clock in the morning, I'm like, oh God, I got to go potty. So I go into the bathroom, again, that devious bathroom. I have like 102 fever. I'm sitting there, and I'm just sitting there. Nothing's happening. Like literally just sitting there. Next thing I know, I'm like, I'm really tired. And I feel like I'm falling asleep. Like, when you're nodding off, that's exactly what I was doing. Next thing I know, I don't know how long it was later, I wake up, and now I'm face first into the bathroom or into the bathtub, and I'm leaning over the edge of the bathtub. And I'm like, ooh, I wonder if I just fell off of the toilet, or did I have another syncopal episode? Being the great patient that I am, I went back to bed. So I end up going back to bed, wake up in the morning. The cardiologist's office calls me at 9:03, and they're like, hey, Mr. Turek, you had a significant cardiac event last night. And I was like, oh, did I? Playing dumb. And they're like, yep, the cardiologist is going to call you back shortly as soon as they're done seeing the patient. Stand by the phone. I'm like, okay, this can't be that bad. So they call me, and they're like, yep, Mr. Turek, you had a very significant cardiac episode last night. You had a heart rate of 3 over the course of 32 seconds. And I was like, ooh, that's really bad. So ultimately what ended up happening was when you looked at the EKG rhythm, my heart rate went from 70 to 60 to 40 to 30 to 20 to 2 junctional beats. So my SA node had failed. My AV node took over. It put out 2 beats, then 1 beat, and then I had a 6-second pause of nothing. Then I had 1 junctional beat. I had an 8-second pause of nothing. I had a junctional beat, and then I had another 6-second pause of nothing. And then I had 3 junctional couplets, and then I came back up into the 60s. So, and that's literally what the EKG looks like. So they were like, yep, Mr. Turek, you bought yourself a pacemaker. So 2 weeks later, I go into the cath table, and boom, I get my pacemaker surgery done. And this was me, the literal day of the surgery. What I didn't know, I was thinking I would be in there overnight at least, right? You're getting a major surgery done. Nope. It probably could have been done outpatient if it wasn't done in the cath room. And so what I was told is that you can't lift anything, further than like, let me just show you here. You can't lift anything more than this high. Okay. So like the height of your shoulder. And you can't lift more than 5 pounds for up to 8 weeks. You're in the bandage for a day, and then you can take that out and let air get to everything. And I had to be in a sling for 5 days. And I think that was the worst thing of my life, because you had to sleep in it. You had to shower in it. You had to do everything in this sling for 24/7 for 5 days. And that was just ungodly torture. Like, I probably would have rather been like tortured in the military than, wear that darn sling, especially sleeping, because I don't sleep on my back. And now I'm forced to sleep on my back with this darn sling on. So what I learned afterwards was, the picture on the left here, this is an old style pacemaker, right? It is a big box, and these things are like an inch thick, not 2 inches thick, but an inch thick, maybe 2 inches long. And they put it, up here, in the top of the left pec, and you can clearly see it. It's like, yep, that is clearly a pacemaker. This is mine here on the left, or on the right. This is my incision scar. Thank God that they didn't butcher my tattoo. That was the only thing that I asked them not to do, was be gentle with my tattoo. And so this was my incision scar. And then they created a pocket right here, underneath the muscle, not underneath the skin. So it's really deep. And so it doesn't create a bulge. It literally is flat skin. Now, when you press it, you'll feel it, but you won't see it from the outside. So if you're doing your assessment, you need to actually do the look, listen, feel portion in your ABCs to actually be able to know, like, hey, this guy's got a pacemaker. Otherwise, you never know, right? Now, the other thing too is my pacemaker is the size of a silver dollar, in like width, and in thickness, it's the size of 2 silver dollars stacked on top of each other. So we went from an inch by 2 inches to a silver dollar and 2 silver dollars stacked on top of each other. That's how tiny these things are now. So let's look at what actually makes up a pacemaker. So this is the bulk, computer of the actual device. So it's the implantable pulse generator called the IPG. And this whole thing is the IPG. I put this little white dotted line on it because on the left is the computer chip. That's what actually runs the whole operation. On the right of the dotted line is the battery. Now, depending on how often and frequent you use your pacemaker depends the life of the battery. So typically someone might get 5 to 12 years out of it if they use it heavily. Whereas like me, I don't use mine very frequently at all. So mine is like slotted for 12 to 15 years, which is really nice. Okay. So the IPG is the implantable pulse generator. That is the actual computer that runs the whole system. Then you actually have the leads. Okay. Now the leads conduct that electrical charge from the pulse generator. And they connect directly to the pulse generator, and then they are secured into the myocardium muscle themselves. So one of the things that they found out through testing was that they stopped using conductor wire that was straight, and they went to this coiled conductor wire. Because think about like a phone cord, right? The old style phone cord from the 90s, the cord, you could sit and talk in your kitchen and then walk 30 feet away and it just coiled right back up, right? Whereas if you did that with a piece of straight wire, it would bend, it would kink, it would like turn 90 degrees and you'd never be able to get it straight again. Okay, so they found that this was a better system for all of that movement inside the body. So you have a coiled conductor, then you have the electrodes on the end. So this one is a flat electrode. This one is a screw electrode, and those actually touch the myocardium. So the screw electrode, they will actually screw it into the myocardium, and then the myocardium grows around it, scar tissue's in, and that's how it's held in there. Whereas with the tine one, this one on the top, they cut a little hole, they stick it in there like a fish hook, and then it grows around it, and you can't pull it out like a barbed fish hook. All right. But this bottom electrode is still touching the myocardium, and this is where the pulse is actually generated from. So it comes down the conductor, it hits the electrode, and it provides the shock into the myocardium muscle. Now, because this is an electrical circuit, you need a circular flow of electricity. So there's unipolar and there's bipolar. Unipolar, we have the positive, which is where the pulse is generated, right? So the pulse is generated at the IPG, the pulse generator, and then it's moved down to the negative, and that's where you have the unload of the electricity. Then it has to go back through all of the chest tissue to get back to the positive piece in the unipolar, pacemaker. So you might see, if you're ALS, you might see some irregularity on your EKG from like artifact, because the electrical activity is actually going through the chest muscle on a unipolar device. Whereas on a bipolar device, the anode and the cathode, the positive and negative, are right next to each other. So we go back to this piece, these would be bipolar. This black piece is where your positive is. It goes to the negative, and then it goes right back to the positive. Okay, this is my kind of device. I think it is a whole lot nicer than the unipolars. So you have single, dual chamber. So single chamber would be it's pacing one chamber. We'll go into this. Dual chamber is it's pacing 2. Biventricular is it's pacing 3. And then pacemaker defibrillator is not really one on its own, right? You can add a defibrillator to any of these pacemakers. It's like a special add-on for like your luxury car. Okay. So here's your single chamber. You have your implantable pulse generator, IPG, your computer, and notice how it only has one connection point for one lead. Okay. That's why it's single chamber. So here's a great picture of where they would implant the device. And then here is it coming through the subclavian vein all the way down into the right atrium. This one might be in the right ventricle, depending on how low that is. But it's either going to be in the right atrium or the right ventricle. It's not going to get fished into the left side. Now, typically, if you have patients that don't need cardiac output, like they don't need a bump in cardiac output, they just need a rhythm generated. Maybe, this is to slow a rhythm down from a rapid AFib or something like that. They're still getting really good cardiac output, but their rate is too high. They'll do single chamber. Okay. Whereas like me, I pass out because I lose all my cardiac output. I needed a bump in cardiac output. So they put me in the dual chamber category, because the dual chamber will give you that bump in cardiac output. So again, here's your pulse generator. Now we have 2 connection points, 1 for each lead. So here's, this is not my EKG. I wish I could get a picture of my EKG, or not EKG, my X-ray. But you see the tines, or not the tines, but the screws here. And that is the kind that I actually have. They didn't use the tines on me. But this will go, 1 will go into the right atrium, and then 1 will go into the right ventricle. And again, this gives you that cardiac output bump, which is what we want. All right, so moving right along to, I was just looking to see if you guys did any updates in the chat there, but nope, that's all right. So the biventricular, right? This has 3 leads. So we've gone 1, 2, 3. We're working in progression of more and more, right? It's also, the biventricular also can be called a cardiac resynchronization therapy, or CRT. You might see that on these devices like this one, has it printed right on the actual computer, or they might give you a card that says, hey, you have a CRT device. So have you guys ever heard of a structure inside the heart called the coronary sinus? Now we've heard all about the coronary arteries, but not a lot of people hear of the coronary sinus. And hopefully after tonight, you understand what it is, and you can be like, hey, what's the coronary sinus, to that, paramedic or EMT that knows everything, and you can go and stump them and be like, ha ha, you didn't know everything. So in the posterior of your heart, the back of your heart, you have this giant vein called the coronary sinus. So off of your aorta, you have the coronary arteries. So blood goes out of the aorta, it comes back, it flows into the coronary arteries, perfuses the heart. And where does all that blood go? It all drains into the coronary sinus and then goes back into the inferior vena cava. So that is how we actually perfuse all of the heart, the in and the out of the blood flow through the coronary arteries and then into the coronary sinus. So why is this important in pacemakers? Well, because they actually utilize the coronary sinus to put in the left ventricular lead. So your right atrium lead, right, is here in the picture. That would be, through the subclavian vein, just like mine is, right? And then the next one goes into the right ventricle, and then they go down in and they fish it into that coronary sinus and they pull it out into the left ventricle. So that is, and again, we're not pacing the left atrium here. This is for typically full on heart failure patients or full on like 3rd degree heart block patients that have no ability to contract their ventricles on their own. That's who get the CRT or the biventricular device. The coolest thing, and I was actually offered one of these, is a leadless pacemaker. These were first brought to fruition on the market in and around 2013 here in the United States. And these are about the size of a pill. So you think about the size between like a dime, a penny, like, the biggest one is about the size of a quarter. But think about like the biggest horse pill, penicillin pill, or, whatever infection, bacteria, I can't think of the name, antibiotic pill that you guys have taken. That's about how big these are. And they only go into the right ventricle, but literally they are screwed right into the myocardium. And it is a computer chip on its own. And when it senses that you need to be paced, it sends out an electrical charge through the bottom. I was offered one of these, but then they talked me out of it solely because they wanted that extra cardiac output. So they wanted to put the dual lead in the right atrium and the right ventricle. But something to look out for, because these, no one will have a big box or even a small like pad like I do in my chest. So what do you guys think about defibrillation? Can we do it on a patient with a defibrillator? Well, I would surely hope that you guys are shaking your heads like, yeah, we need to do that, right? So if you need to defibrillate your patient, you just need to make sure that you find where the pacemaker is, because remember that you can put a pacemaker, typically it's on the left, in the left shoulder, but you can also put it on the right. And I could have asked for it on the right, and that would have helped my hunting ability, because I lost the ability to shoot on my left side, which I've done since I was a kid. So now I had to retrain everything and shoot on my right, which is just weird. But yeah, so you can have it on both sides. Now, if it's on the left, you're going to put your pad on the right and you're going to put it on, the side, and nothing changes, right? You could put it in the center and you could put it on the posterior. Nothing changes. However, if you do feel around and you feel a pacemaker on the right, now you just have to think, okay, I have to be 1 inch away from the end of the pacemaker. They are making pacemakers that are safe for defibrillation. They can take the load of the shock as long as it's not sitting right over the pacemaker. It has to be at least 1 inch away. So just keep that in the back of your mind. So when we're talking about assessments, we want to talk about specific things. You're going to do your ABCs. You're going to do your cardiac exam. You're going to look for JVD. You're going to look for tracheal deviation. You're going to look for, fluid pooling and edema and chest pain and all that different kinds of stuff that you would do on a normal BLS assessment. You're going to do your OP, QRST, and sample. I want you to ask all of the normal penetrating questions. But then every single pacemaker patient should have an EKG done, okay? If you can do a BLS 12 lead, do that and then just send it to the hospital, and maybe you don't have to call for a paramedic, or call for a paramedic and have them do it, right? And just be like, hey, yeah, they have a pacemaker. We really need to be able to get what that pacemaker looks like and what it's doing, right? We'll talk about getting device info and utilization specifics, because we want to make sure that we're going more in depth than just how often does it go off. Okay. These are some of the questions I want you guys to start asking. So take a picture, right? Why and when was it implanted? So for me, the why would be symptomatic bradycardia. I've had 15 or 20 different episodes in the course of my life since 10 or 12. And my heart rate dropped to below 5 and they decided it was time for a pacemaker. When? I had it done in September of 2020, right? So I've had it for 2 years now. Okay. How many chambers does it actually, pace? Does it do 1? Does it do 2? Or does it do 3? Okay. When and how does it activate? We still ask this, but now I can tell you guys that it is a very, very more specific thing about pacemakers and how they actually activate. So mine is set for, it's an on-demand pacemaker. So it's used when it needs to be, right? It's not a all the time pacemaker. And mine is set for anything less than 50. So if my heart rate hits 49, my pacemaker activates and it will immediately give me 3 zaps. It will go boom, 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 right? And then while it's giving me the boom, 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 it calculates the average of my heart rate over the course of the last 24 hours. So if it calculates that my heart rate has been an average of 65 for the last 24 hours, it will then bump me up and pace me 20 beats over that average. And it will do this for 2 minutes. So my pacemaker will go boom, 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 and then it will increase to 85 and pace me for 2 minutes. So after 2 minutes and 3 seconds, because that's how long mine goes for, it shuts down. And then it reevaluates, okay, is his heart rate staying above 50? Or is it still in the 30s or the 20s or the 5s or whatever? And then it'll start over again, okay? So most patients should know this. Is your 90-year-old patient that doesn't know if they have high blood pressure or not going to know this? Maybe not, okay? Still try and ask, hey, do you know how and when this thing activates? Do you know how it pulses you, right? This is information that we need to have. Last device testing is a new one for me. I get a device test every 6 months. I go to the cardiologist's office. They put a giant magnet over it and they can literally test everything about it. They can slow it down. They can speed it up. They literally put my heart rate at like 130 and they're like, yep, Mr. Turk, you're going to feel it fluttering in your chest. We're going to jack it up, make sure everything's working good. They look to see how often I use it. Do I use the atrial lead? Do I use the ventricular lead? How often do I use one or the other or both? And they can tell all of this just by that computer chip and reading it with the device computer that they have in the office. Now, one of the things that's really cool is if they see something that they don't like, they'll tweak the settings. So last time that I was in getting tested, they noticed that all of my informational data was spitting out that I had SVTs, or supraventricular tachycardias, like heart rates of 160 or more very frequently. And they're like, but your pacemaker's not pacing you down, but it should. So they were like, they looked into a little bit more and they were like, oh, well, your Q waves are really tall. Or I'm sorry, your R waves are really tall. And I was like, well, I don't know what that means. And they're like, well, for a young person has really high R waves, and you measure out your pulse in the pacemaker by the measure of the R waves. So if you have really tall ones and maybe you're tachycardic because you just ran up a hill and your heart rate is 120, those R waves are so high that it tricks the pacemaker into thinking that you're at 200. But underlying, it sees that you're really only at 120, so it doesn't pace you, but it still reports that you were in SVT. So I was like, okay, well, how do we fix this? So they literally turned down the amplitude threshold for my R waves, and they're like, yep, we'll see in 6 months to see if this fixed it. And I was like, I didn't even know that this was a thing. So again, the intricacies of these devices is wild. So every patient has one of these. Okay. This is mine. And, it is your device information. It is specific to the device that they implant into your body. So it has your name. It has the manufacturer, right? Mine is Boston Scientific. Okay. It has the physician, the electrophysiologist that actually put it in. Okay, this is not my normal cardiologist. This is my electrophysiologist that literally cut me open and put it in there. And their telephone number. Okay, then it tells you what I actually have, the model and serial numbers. I scratched it out so you guys didn't hack me. That'd be really fun, like give me a seizure. And then the implantation device or date. Okay. Look and ask for this, because if they're having a problem with their pacemaker, now you have all the information. You could call the physician's office while you're on scene and be like, hey, I'm paramedic, or EMT, so-and-so from so-and-so agency. I'm here with so-and-so. They gave me permission to call you. It sounds and looks like they're having a problem with their pacemaker. Here is all of their information. What can we do about this situation, if anything? Before we leave the scene, we can go and we can do something really radical. Every single patient, along with their card, has a base station. This is what mine looks like. This green light is so freaking bright at night. I put a piece of tape over it just so I could sleep. But this has to be 15 feet from my bedside. It has to be, okay? Because they set your pacemaker, the Bluetooth enabled piece of, technology in your pacemaker is attached to this exact box, right? Everyone's is attached to their specific box. And they say, at least in my case, every day at 4 a.m., all of my information from my pacemaker is uploaded to this base station. This base station is then attached to wireless, cell service. And my cardiologist office can go, all right, update Mr. Turek's, EKG reports, send. And it gets uploaded from this base station into the cardiology cloud at the office. And then they can literally go on the computer. They can double click, the last 4 months, however long they want. And they can see all of the times that it activated. It can see all the EKGs on why it activated. It can see everything. So one of the cool things is if you see one of these with your patient, and maybe your patient had like a syncopal episode or something, and you're like, I wonder what caused the syncopal episode. You don't have a paramedic on board to sit there and go, well, they're bradycardic in the 30s, or, maybe they're tachycardic in the 190s. Maybe that's what caused it. Maybe you go, hey, sir, ma'am, what is your cardiologist number? Am I able to call them and download some of your data? You give the cardiologist's office a call and you say, hey, I'm here with so-and-so. They have a base station. Can you upload it really quick and tell me what the last hour looks like, right? They'll be able to sit there and go, oh yeah, look, they had a heart rate of 4. You know, maybe that's why they passed out. Now you can give even further information just based off of a phone call, talking to an office, to the hospital and that cardiologist that might be able to do something for them later on. So it's a really good piece of information just to stick in the back of your noodle. All right. Again, what can we find out? How we can find out? We just said, call the office if they have a base station, because they should, and get that uploaded to the office so that they can tell you what happened. All right. So if there's any paramedics on the stream, I don't know if there are, but we'll go through this really quick. EKGs are paramount with any type of patient that has any of these complaints, right? So any type of cardiac complaints, any syncope complaints, any altered mental status, and any type of just general ill feeling. I'm one, and many people will disagree with me for this, but people don't pass out for a reason. So every single syncope call that I go to gets transported ALS no matter what. It could be 5 seconds long and they're completely alert and oriented, feel fine. They still get a cardiac monitor, they get a 12 lead, and they go to the hospital with me. People don't pass out for no reason. So you should be doing EKGs with all of these, and for people that have pacemakers. All right. So this is what you're looking for, or should see with atrial pacing. So they're pacing the right atrium. You should see a pacer spike like this, where your P wave would be right before your normal size or normal width QRS complex. With ventricular pacing, you're going to have a normal P wave, right? Or you should. And then you'll have your itty bitty spike, right? You can see your spikes right here, just before your QRS complex. Now your QRS complex is going to be wider because you're starting the electrical impulse down in the ventricles. It has to go through the Purkinje fibers, then it has to go up and then come back down. So it widens out the QRS complex. All right, dual chamber, you should see 2 pacer spikes, right? Because you're doing the atriums and the ventricles. So here's your P wave, pacemaker spike, and then here is your ventricular pacer spike, right? So here's your, this one's a little better here. Here is your atrial pacer. Here is your ventricular pacer, right? Just like when we would be pacing somebody that doesn't have a pacemaker but is symptomatic bradycardia, you need to make sure that capture is present, right? This is, we're testing for if that pacemaker is active and working. So we see electrical capture on the monitor, we see a paced rhythm, but do we have a radial or a carotid pulse, right? Is there correlation there? Okay. Is the rate accurate for their presentation? So are they looking like dirt? They're looking like shit, but they have a heart rate of 90. And it's like, well, that doesn't make any sense, right? I can go into an entire lecture on this. I'm not going to today, but is ischemia present in a paced rhythm? You're going to do Scarbosa criteria for that. And could the device actually be the problem? Could it be a malfunction in the computer itself? Maybe the battery died. Maybe there's some form of, something hit it and it broke something inside, right? These are delicate things. I'm still told all the time, 2 years later, don't hit your pacemaker. This is the last slide, but I want you guys to take a really, close look at this. We talk about trauma, but we don't really talk about pacemaker trauma, right? This was a picture that was given to me by my one boss. He took it a couple years ago with permission of this patient. And here is a biventricular CRT device. Okay. You see the 3 leads. Okay. He had this put in 2 weeks prior to this happening. And he said that the site that they put it in got infected and then turned necrotic. So the tissue itself started to get eaten and die. And what happened was he was in bed and he rolled over and he heard like a popping sound. Next thing you know, he looks over and his pacemaker is hanging out of his chest because it literally just broke the skin and popped through the skin. So wild call, right? My boss ended up saying that literally all he did was pack it and secure it directly to the chest wall to make sure it didn't move, because he still had a pulse rhythm, like a pacer rhythm on the monitor. So one of the things is, again, remember that, you know, the biventricular pacers that have the 3 leads, they are there for heart failure patients and or really sick hearts or heart block patients, complete heart block patients. So if one of these leads cracked or detached or did something like that, that dude is dead, right? You're going to have to then take over pacing and put the R pads on and start pacing, you know, because this thing's literally going to shut off or malfunction to the point where it's no longer working. So we wanted to make sure that this was completely secured to the body so it didn't move. So, so that's what I got. Hopefully that was informative to you guys. Let me go over here. All right, so let's see what we have on the chat. All right, so let's say, Blaine, I take it your surprised face was when I had a heart rate of 3. That's typically the face that I get is, oh my God, that was really bad. And it was. I didn't think it was going to be really bad until I saw the EKG rhythm. And then I was like, oh yeah, that was really, really bad. All right. So if you're dispatched to a working code and your patient has a pacemaker, would you do anything differently than if you had called, if you're called for a working code for a patient without a pacemaker? Absolutely not. So the pacemaker is not in the way, so you can do CPR. It might still be activated, right? But you will not be getting, there's that electrical capture and that mechanical capture mismatch. So I couldn't tell you how many, it's the weirdest thing, and I'll be there one day because I'll have this till I die. And it's the weirdest thing. I've seen, you know, patients that are deceased and their pacemaker's still activating, and I put them on the monitor and there's still a paced rhythm, but they're blue with lividity and purple and no pulse, but there's still a paced rhythm on the monitor. And I'm like, that is so weird. It's the creepiest, weirdest feeling in the world. It's like a walking zombie. But yeah, so all you do if you're a paramedic in this spot, you're going to see a paced rhythm and you're going to check for a pulse. If you're, and you won't feel one because there's electrical activity, but the heart muscle can't actually do anything. Right. Whereas if you're a BLS person, you're going to do the same thing you always do. You're going to do circulation airway breathing. So you're going to walk up, they're not breathing, they're unresponsive. You go and check a radial and a carotid pulse. You're not going to feel anything. You don't even know they have a pacemaker at this point unless you knew the patient prior, and you're going to start CPR anyway. Nothing is going to change in your treatment of these patients. Let's see. Can you feel it activate? Abso-freaking-lutely. A lot of patients can't. That's okay. Like, you don't have to. What makes mine oddly weird in that I can is that it's the one lead, and I don't honestly know which lead it is. It could be the atrial lead. It could be the ventricular lead. I'm assuming it's the atrial lead because that's the one I use all the time. On every single one of my statistical datas, I've never used my ventricular lead. I only ever use my atrial lead. So 100% of the time I use that lead, and every single time I feel it activate, the lead runs so close to my esophagus that the electrical charge coming through that coiled conductor wire will actually go through the vascular wall and tickle my esophagus. So then I get like this weird frog in my throat, and then I feel the pulse, and then all of a sudden I'll start hacking up a lung. Like, I'll just start coughing because I get laryngospasms, and I start coughing because it's pulsating my esophagus. I'm not a smoker, and I'll just start like hacking up a lung for a good minute, and then it'll go away. And, then I won't feel it until the next time it activates. And a lot of people were like, oh my God, like, are you sick? And I'm like, no, it's just my pacemaker going off. And they're like, what? It's a great introduction technique. You guys should try it. Works great for parties or EMT classes when I'm sitting in the middle of a lecture. And next thing you know, I'm like, and I'm like, no, I'm fine. It's just my pacemaker. And they're like, what? It actually happened. Blaine, I don't know if you remember, because I know you listen to the podcast. I don't know if you remember that there was one episode that right at the start of the episode, like the music's playing, I'm about to say hello and welcome to the Medic Materials podcast, and all I'm doing is hacking. I'm coughing because it was the one and only time that we were recording when it went off during the recording. And, I'm sitting there and I'm hacking up a lung, and Kelsey's like, oh, pacemaker's going off. And, Gerard's like, oh, don't die over there, or whatever they were saying. They were poking fun at me because they think it's funny now. But yeah, so I do actually feel it, which is funny. I don't feel it all the time, but I feel it a lot of the time. Which is, yeah, it's wild. I agree. It's very wild. All right, I'm going to eat a Starburst. So if I chew, now you know what I'm doing. Do you guys have any other questions? At least, pacemaker-wise or anything else BLS-wise? Let's see here. I have no idea where Gerard went. Assuming, maybe I should try and give him a call. Be like, hey. So one of the things I did want to mention to you guys is if you are a Patreon subscriber, which the link is in the description of this video. If you want to become a Patreon subscriber, Gerard and I are launching a brand new show that is Patreon exclusive. The Salty Veteran tier will be getting the brand new episodic Patreon TV show, whatever the heck we want to call it. Yeah, right. Nice of him to join us. I agree. Jerk. But yeah, so Gerard, as a lot of people knew, Gerard has left New York. He's moved, to the southern bunker, and he's gone through a lot of different things. And one of the things that he was like, hey, I want to talk about it like on a show, make it for the patrons because, we love them and we thank them for everything that they do to support us. So we want to give back to them a little bit more. And, one of the things that we did in the podcast is we kind of let you into our little world and our little bubble, but we do it in a matter of, it's very boxy. It's very limited, whereas this show, Gerard really wants to, have like the conversations that him and I have around the, couch and dinner table when we would come over and have barbecue and have beverages and just chill and hang out. And, he wants to talk about his experiences in a new system and, how he's, getting used to all this. And it's a good way for him and I to still keep in contact other than just the show and talk about life and stuff. So, if that's something that interests you guys, it's him and I are hoping to make it a weekly thing. What day that falls on, I don't know. We're launching it on a Saturday. It might not stay on a Saturday. But it's going to be very intimate. It's going to be fun. We probably are going to have some medical discussions because like I said, he's going to be talking about work down there, and just the differences that, they are compared to here. And, he was telling me about one call. He's like, let me get your opinion. And I was like, oh, you don't want my opinion on this one after he tells me it. And I was like, oh my damn. But yeah, so it's going to be something like that. And I think it's going to be a lot of fun. And, it really, again, why we're not putting it out anywhere where it's, free is because it really means a lot to us, and, and it's close to our heart. So we're hoping that, it's something that we can bond with our Patreon subscribers a little bit more intimately, if that ramble makes any type of sense. But, yeah. Anything else, guys? Otherwise, that was a good solid hour. I hope that you at least took something away from this pacemaker discussion. These streams are going to be every other week. I don't know if we're going to do every week yet. I'm still in the midst of my EMT class, and that is literally driving me up the wall of things to do in my life. I still have to prepare for winter and, do all of my firewood to heat my new house over the course of the New York winter. And it's just the balance of trying to find everything, find the time to do everything. But hopefully I can get these streams up. Hopefully I'm going to start bringing in new guests, so we'll have a little bit more of a discussion between people. If you guys want to hear call reviews, let me know, because I think it would be really cool to review a call with you guys that you can pop in the chat and be like, yeah, this is totally what I would do, or I would give epi in this situation. And oh my God, that guy was such an idiot. I think that would be a lot of fun. And I love doing call reviews. If you've heard the podcast, you know that it's more or less what we do on that show. And we have a blast doing it. So I'm going to say farewell and stay safe to you guys tonight, if that's everything. Thank you again for joining me. Thank you again for subscribing to the show. Subscribe if you haven't. And again, if you decide to, check us out on Patreon, the link is below. And if you decide to, subscribe to us there, thank you very much for your support in the monetary fashion. And till next time, guys, stay safe. And most importantly, donuts.